Good afternoon, ladies and gentlemen. Thank you for the kind invitation and for the kind introduction. First of all, I must thank Professor Haridesing for inviting me to deliver this speech in this distinguished forum. I will be talking to you on the programs. Hope that all of you can see my presentation. So I will be talking to you on programs for controlling micronutrient deficiencies and stunting in Sri Lanka. During these 18 minutes, I will take you through the programs for controlling micronutrient deficiencies, malnutrition, and stunting in Sri Lanka. I will not be able to take you through how successful and how the burden was reduced by these programs. As all of you know, Sri Lanka is a small island located in the Indian Ocean, having a total area of 65,610 square kilometers of size, and it is having a total population of 21.2 million. We are a multi-ethnic, multi-religious country, but living in harmony as a one nation. So Sri Lanka is a country full of natural resources and also full of natural fauna and flora. And we are blessed with a lot of fruits and vegetables. Although we are experiencing a triple burden of nutritional disorders, undernutrition, overnutrition and obesity, and the other one is micronutrient deficiencies. I will just want to take you through our healthcare system. Sri Lanka has a very strong healthcare system. I can describe those under two arms as preventive and curative healthcare system. These control programs to control the micronutrient deficiencies and the malnutrition stunting is mainly looked after by this preventive care system. Although this is a very crowded image, I would like to show you that in our healthcare system, the two areas, preventive care system and the curative care system, is there at different levels. It is organized, and the preventive care system is much more stronger than the curative healthcare system, by which these controlling programs are executed. So what are the main micronutrient deficiencies that we are experiencing and are being controlled by these programs? Iron, iodine, vitamin A, zinc, and calcium. And recently we have found out several other micronutrient deficiencies as well, but these are the main micronutrients which are being addressed in the control programs. Most of the times, we found that the individuals are experiencing multiple micronutrient deficiencies. Among the vulnerable group of having micronutrient deficiencies, pregnant mothers, lactating mothers, infants and young children are elderly, and elderly are included. In my speech, I will mainly focus on pregnant and lactating mothers, infants and young children. These control programs are mainly looked after by the Ministry of Health and Indigenous Medical Services of the country with the help of Family Health Bureau and other NGOs attached to those. First, we will look at what are the programs which are involved in maternal nutrition and well-being. All the pregnant mothers who are pregnant get registered themselves at the public health midwives, which are who are attached to the medical officer of health areas and at the local setup. After registering, they get standard intervention package that includes preconceptional folic acid. The mothers who are expecting to have babies, they are advised to get folic acid even before the pregnancy. These mothers should get registered before 8 weeks of gestation at the antenatal clinic. And the mothers, after getting themselves registered, they are being screened for various diseases, which include infectious diseases as well as some other screening programs. I have listed here only the relevant ones to this session. And the mother specifically screened for diabetes before 12 weeks of gestation, and then they are screened for anemia before 12 weeks of gestation, and they are assessed. They undergo nutritional assessment before 12 weeks of gestation using body mass index. If they are found to have abnormalities in body mass index, maybe underweight or overweight, they are being appropriately counseled and appropriate nutritional interventions are offered for them. And there is a place of micronutrient supplementations under maternal care, and there is a food called triposha. A fortified food is offered for mothers. And when we look at the Sri Lankan recommendations of micronutrient supplementation for pregnant and lactating mothers, iron is given during the second and third trimesters and continued for 6 months during lactation. Folic acid started before the conception and continued throughout the pregnancy and will be continued for 6 months during lactation. Calcium supplementation is given during the second and third trimesters of the pregnancy and continued for the first 6 months of lactation. Vitamin A megadose is given once only after the delivery, within 4 weeks of delivery. The fortified food item called triposha is given free of charge for all mothers, all pregnant mothers and lactating mothers until the end of first 6 months. That is made locally and given free of charge for mothers. Each mother is getting 2 packs per month, and they are advised to take 50 grams per day as a snack, not as a main meal. They are strongly advised to take this as a snack along with the balanced main meals. And then the strategies to control the malnutrition, stunting, and micronutrient deficiencies among children in Sri Lanka. There are main strategies that we have adhered to: routine, very close growth monitoring, and appropriate intervention done at the clinic visits, and promotion of breastfeeding, appropriate complementary feeding, and the introduction of food-based dietary guideline, supplement programs, deworming treatment, and fortified food. Those are the main strategies that we use. At the clinic visits, children are monitored for their weight, height, and occipital-frontal circumference. All those are recorded in this child health development record, and we monitor the growth of the child, and we can easily spot the growth faltering. And the vaccination, all are being recorded in this child health development record. Until 5 years of age, they are being followed up at the child welfare clinic. In the first 1 year, they have to pay at least 5 visits and get the monitoring done. In the intervention package of the child welfare clinic, vaccination, health screening, deworming treatment, growth and development monitoring, and supplementation are included. When it comes to breastfeeding, we are adhere to international guidelines, and we have separate breastfeeding statement and guidelines laid out. All the babies born should get breastfeeding within first hour from birth, sooner the better. All infants up to 6 months of age should be exclusively breastfed, even during a time of disaster. Children up to the age of 2 years and beyond should be given breast milk along with safe and adequate complementary feeding according to the guidelines that we have laid down. And all the mothers, they are strictly advised not to stop breastfeeding even they have started complementary feeding at the age of 6 months of the baby. To promote breastfeeding, there are mother-baby units and the lactation program specifically designed and approved by the Ministry of Health in 2007, and those are established in almost all hospitals to look after the mother and the baby and to promote the breastfeeding. And recent initiative is there to look after the nutritional problems at the field level. That is the establishment of nutrition clinics at the medical officer of health areas to look after the nutritional problems specifically. So when it comes to complementary feeding, the mothers are advised that guideline is there to introduce complementary feeding appropriately at a appropriate age, 6 months of age, using locally available food items. When that is done, mothers are strictly advised to pay attention to the quality, age-appropriate frequency of food, and quantity and consistency, and the response feeding practices. Safety all are given in the guidelines, and all mothers are trained and they are given with leaflets and flashcards to guide themselves. We have the dietary guidelines and policies laid down. We have food-based dietary guidelines to follow and design the diet, not only for children and pregnant mothers and lactating mothers, and that is for all individuals, all Sri Lankans, that they can follow. And there are guidelines, healthy canteen guidelines defined for workplaces and schools. These are some of those. When we look at the micronutrient supplementation for children under 5 years, vitamin A mega dose is given every 6 months from the age of 6 months to 5 years. Multiple micronutrient supplementations having iron, zinc, vitamin C, folic acid is given as a sachet at 6, 12 and 18 months for a period of 60 days. When that is not available, these are given separately. Zinc supplementations have been started in 2013. When diarrhea is there with the child, it is given for 10 to 14 days. And this is for the babies who are born at term having normal birth weight. There is a different schedule for preterm and low birth weight babies. When we discuss about the deworming guidelines, that has been recently changed in 2019. The guidelines for under 5 years old children is that the routine deworming treatment is given for children aged 18 months to 10 years with a single dose of mebendazole at 18 months, 2 months, 3 months, 4 months, and 5 years of age. However, this has been defined according to the risk. By the survey done in 2017, they have redefined the risk districts. So, depending on the district from the child list, the guideline is different. If the child is from high risk district, when the prevalence is more than 10%, the deworming treatment is given for 4 years, starting from 2019 to 2022. And if the child is from a low risk district, they don't need routine deworming treatment. They need individual treatment. If the child is found to have the infection, only they are given treatment. The micronutrient supplementation and deworming for school children, that is also happening in Sri Lanka. And the guidelines have been defined, revised in 2019. And if the child is between 6 to 10 years old, iron, vitamin supplementations are given once a week for 6 months per year. At the same time, they are given with routine deworming treatment if they are from high risk and intermediate risk districts. That is given for all children from grade 1 to 5 once a year. The micronutrient supplementation is given for children above 11 years as well, in the same way, in the same schedule, but there is a difference of the iron dosage that is little higher than the previous group. and they are not given with routine deworming treatment. By the survey in 2017, they have found that the prevalence of soil-transmitted helminth disease is very much less in this category. So they are not given with routine deworming treatment. Children are also given with triposure. For children who are undernourished, from 6 months to 5 years, they are also beneficiaries of receiving triposure if they fulfill the following criteria. There are guidelines in our setting to manage a child with acute malnutrition. Those are being managed at therapeutic care and curative care setting, and also there is a food item, ready-to-use food item called B100, given for these children who are having acute malnutrition. Pregnant mothers, based on the routine, based on the revised guidelines, pregnant mothers are not given deworming treatment routinely. But if they are identified having the disease, they are being treated with albendazole after confirming only. These are revised guidelines. Earlier, that was given for all mothers routinely. And as all of you know, iodine deficiency, severe iodine deficiency affect the children. It is associated with mental retardation and stunting, and that can affect in utero and after birth. And in Sri Lanka, iodization of edible salt is mandatory. That is implemented since 2005. And with that, children older than 1 year and all the adults, including pregnant and lactating mothers, they are given with iodine, iodized salt. When it comes to fortification of other food, that is very, very minimal. Rice fortification and wheat flour fortification with micronutrients, that is still under discussion. It is happening in small scale by voluntary basis, but that is still not mandatory in the country. Thank you. That is the overview of the controlling programs in our country, and thank you very much.
Thank you very much. Well, in this session, the subject of my presentation is a complementary feeding education model preventing stunting experience in Aceh Province, Indonesia. My name is Dr. Nnam Ngozi from Health Polytechnic of Aceh and Food and Nutrition Societies of Aceh. This topic is part of our activities in Aceh to prevent stunting, especially for children under 2 years. And the outline of my presentation is stunting and it causes problem in breastfeeding and complementary feeding in Aceh, an educational model for complementary feeding and breastfeeding, success story and challenge, conclusion and recommendation. Okay, the first step, I will present about the prevalence of stunting by district in Aceh. From the graph, we can see the stunting problem in Aceh is very, very seriously category. Yes, according to basic health survey by Ministry of Health in 2011, prevalence of stunting in Aceh is 37.3%. And the last data from nutritional survey on under 5 children in Indonesia called SSGBI slightly decreased to be 34.1%. And you can see all districts in Aceh have a problem with stunting, with high and very high category. Only 4 districts at the medium level of prevalence. And then from some research in Aceh, connecting or linking with causes of stunting in Aceh. Yeah. As is common in various regions in Indonesia, one of the causes of stunting is children is related to nutritional intake, and this in under 2 years children is related to breastfeeding and complementary feeding practice. Based on several research in Indonesia, so breastfeeding and complementary feeding practice still problem. We can see, yeah, in Aceh only one, yeah, only one children, yeah, from 3 children has acceptable practice, complementary feeding practice, and some reference states, yeah, such as WHO in 2015 state less than children, yeah, quarter children aged 6 to 23 months in developing countries receive acceptable. Lack of nutritional intake from complementary feeding practice, yeah, cause a growth disorder and high risk of suffering from stunting. And one of strategy to prevention micronutrient deficiency can be done by nutrition education. World Bank in 2010 states one of 3 intervention effectives to improve nutrition outcome are the complementary feeding or therapeutic feeding intervention. And by the honest et al., yeah, state one of the effort can be done to prevent or undernutrition and growth disorder by improving complementary feeding practice through nutrition education. We can see in this slide from some research, yes. This is from my research in Aceh in 2018 in Aceh Besar district. So less than half of under 2 years children have minimum acceptable diet according to WHO recommendation on infant and young child feeding, and less than half, yeah, timely introduce of complementary feeding at 6 months of age. From this study also show that the frequency of consumption of protein, vitamin A, and iron food source is still low. This condition is due to the knowledge of mother about complementary feeding practice is low. Only 20.2% mother have food categories from my research, yes, from this research. Several problems and barriers in implementation of nutrition education in Aceh are still limited nutrition education model, tools, and media. We can see from this slide, low quality of complementary feeding, dietary diversity score, minimum meal frequency, minimum acceptable diet, and food consumption source of protein, iron, vitamin is still low. Mother or caregiver knowledge about complementary feeding standard still. Some barriers, limited model, strategy, media, and tools. There is no practical tools for mother to assess complementary feeding practice. There is no monitoring and evaluation for nutrition education program. And the knowledge and skill and self-confidence of community health worker in Indonesia called cadre, yeah, still low. So needed a nutrition education model by specific method, simple tools, equip supporting media, easy to use, performed by trained. Based on the problem, we in Aceh have tried to create a nutrition education model that is easy for mother and cadre to understand and use. The development is carried by the model referring to the content to and Kulwa theory through 6 steps. The first step is need assessment for conduct by the formative study and literature study. And the step 2, identifying intervention, perform, and change objective. And the third step, selection of theory-based intervention used in this model using theory of plan we have here. And the fourth step, developing the nutrition education intervention and pre-testing. And the 5th step, implementing plan of nutrition intervention. And the last step is evaluation nutrition education model. The goal of education model, complementary feeding education model, number one is to improving knowledge, attitude, motivation, perceived behavior, control, intention of mother or caregiver about complementary feeding. And number two, to improving complementary feeding practice according to WHO recommendation. Minimum meal frequency, minimum dietary diversity, and minimum acceptable diet. And the outcome of the education model is improving growth and prevention of stunting in under 2 years children. The concept of nutrition education model using food monitoring card. This model called food monitoring card model. Strategy in this model is a combination of nutrition education by using food monitoring card and other media. In this model is booklet and poster by cadre or community health worker or educational personnel, face-to-face nutrition education through home visit. Media and tool used in this model is are for food monitoring card, booklet and poster, and key message. Yeah, the message very adopted by WHO about providing complementary feeding, yeah, and provided to the result. Key message in this model is meal frequency of complementary feeding, the dietary diversity, intake specific food, nutrient density, hygiene on preparation and processing of complementary feeding, responsive feeding. The delivery platform in this model is using a community-based approach to modify traditional practice through interpersonal approach and individual motivation through FNC and other media and direct education by cadre. The step of education by the cadre consists of number one, cadre describe the using of FNC and other media that are both booklet and poster. And then cadre evaluate the feeling of FNC by mother. Cadre record the complementary feeding practice based on food monitoring card. And cadre communicate key message and explain message using booklet and poster. And number five, cadre listen to the issue related to complementary feeding practice and keep motivation to mother. And number six, cadre remind to fill out food monitoring card according to practice that have been done. The number of education session, 24 session with a duration of 45 minutes per session, conducted every week for 6 months. And educational personnel is cadre in Indonesia called cadre community or community health worker with a ratio 1 by 5, one cadre give education to 5 mothers. And the key message of in this nutritional model are continuous breastfeeding, meal frequency, nutrient density, food diversity, specific food intake, hygiene and food preparation and processing, responsibility. The detail of key message and recommendation will be cadre or community health workers send to mother. This is the key message and recommendation. And the form of food monitoring card like this, like in this slide, we divided food monitoring card into three based on the age of children. FNC for number one, and FNC for 6 to 8 months old children, and number two for children 9 to 11 months, and number three FNC for children 12 for to 24 month old children. And in the backhand of the FNC, we explain the guideline of using food monitoring card. And in this model, yeah, to supporting media and for nutrition education, complementary practice, we complete with booklet, yeah, and poster. The booklet content are include the 10 messages about complementary feeding practice according to WHO recommendation, and the poster content about complementary feeding pattern by age and explain about the nutrition, dietary diversity, and other messages in the poster. And the step in the implemented complementary education model by cadre implemented in 3 steps. Yeah. Number step is assessment, asking and listening and observing. The activity of community health worker is ask for the FNC that mother caregiver care as conference, listen and learning to what mother has to say with build self-confidence. And the second step, the cadre conducting, assessing the problem and difficulties experienced by mother. And the step, give information and suggestion by to mother, by THW or community health worker. The state to implement nutrition complementary feeding education model in the community, conduct by step. Yeah. The number step is training supervisor. This is from a health worker or nutrition staff. And the second step, training community health worker or cadre as educator team, and implementing complementary feeding education model, and then meeting community health worker or cadre monthly, yeah, and monitoring and evaluation. In the step and 2-5 step supervised by health worker. The success story of complementary feeding education model in Aceh, combined with food-based intervention that are complementary feeding dispute. Yeah, this pilot conducting in 5 puskesmas or community health center area in Aceh Besar district. Yeah, from the pilot, yes. The nutrition education model, the complementary feeding education model increase knowledge, yeah, attitude, motivation, social norm, safe behavior control, and intention of mother, yeah, compare baseline and inline body. And then from outcome data, yeah, average body weight gain during intervention, yeah, we can see from this figure. Food monitoring card model, education model have increase of weight gains, can help increase children weight better than control. Yeah, compare the control, the weight gain better in complementary food monitoring card model education. And we can can see average body length gain during the intervention. The food monitoring card education model also help increase the length growth of the child body compared than the control group. Okay, the conclusion and recommendation from this president are the complementary feeding nutrition education model using FNC is effective in increasing knowledge, attitude, motivation, social norm, percept, behavior control, and intention of mother. The frequency, minimum meal frequency, the diversity, and acceptable diet in malnourished children is 6 to 28 months. Growth, body weight, and length of underweight children has increased after intervention. The recommendation from this pilot are sustainable nutrition education intervention is needed through a specific and structured program to improve the complementary feeding practice according to World Health Organization standard. And a nutrition education model is needed according to regional condition and the socio-cultural of community so that education is more effective. And the last of this presentation, I want to in the last of this presentation, I want to explain about some tourism visiting to Aceh. Yeah, take us Wet Rahman Green Rescue to Tawar Lake, yeah, Sabang Island, Tsunami Museum. And if you visit to Aceh, don't forget to enjoy Gayo Cafe. Thank you very much for all participants and moderator to opportunity in this symposium. Thank you very much.
Today, as the invitation from Prof Harianto, I just received, I think 3 days ago, yeah, about the webinar today. Try to present about nutrition progress and success factor in Indonesia. I think, as you know, now we are in the era of pandemic. I will present the latest, yeah. First of course, we know the stunting prevention now still getting higher. Then we have a target for reduction until 40% in 2024. But for wasting, this is quite need strong effort to achieve that. Yes, but said that I tried to compile what are the strengths about nutrition program in Indonesia. Not only stunting, wasting, and also NCD and others problem. Actually, the strengths, first, I remember 2011, Indonesia have become a scale up nutrition movement member country. This is, I think this is after we are the member of 100, something like that. This is also one of the global engagement for Indonesia to scale up our program on nutrition. And also, we have 5 years planning. We call, in Indonesia, we call RPJMN or Medium Term Development Plan 2020-2024. This is good also because nutrition target, also indicator intervention include in that regulation. The process, this is also a long time process, how to put nutrition and the regulation through nutrition sector review process. And also we have the President Regulation number 42, 2013 about the scale up. This is follow up after Indonesia become a SAN member country. Try to establish the regulation for scale up nutrition movement. Also, I think this is also a good example at the global level because Indonesia have also government regulation about exclusive breastfeeding. Next, we have a National Strategy for Stunting Reduction movement 2020-2024. This is also a very good example because nowadays the stunting issue handled by the highest level of the government in the office, executive office of the president and also executive office of vice president. Also, we have the coordination and partnership at the national level led by Ministry of Development and Planning. And also we have a task force on networking, skill up nutrition movement, consists of the government, professional organization, NGO, private sector, and development partner. This is our Sun movement of Indonesia. There is a collaboration. The focal point is Ministry of Planning and Development. We have government. Now already have 25 ministries who work on stunting. You can imagine 25 ministers. But this is good, but also have to know how to monitor who does what. This is quite a challenge for us. From development partner, we have 11 agencies. Private sector, we have 40 companies, and also civil society, and also university, including in Pak Toto, in UGM, in IBB, and other university. Yes. For the stunting reduction, we have national strategy, 5 pillars. This is also our strength, our benefit for stunting reduction. The first is commitment and vision of national and sub-national leader. This is very good. The national leader and also governor, mayor, and also wali kota and bupati have to commit and have vision how to do the stunting reduction. The second is the national campaign and behavior change of communication. This is already done by the almost all the sector, almost all the ministry have a national campaign for nutrition reduction. The third is support the convergence of the program at national and sub-national. This is also very good effort how to convergence the program at the national and sub-national. And of course, the fifth is food and nutrition resilience. And the last is the monitoring and evaluation as the important things. We have a strength, but also we have challenge. Of course, the challenge is Indonesia is the big country. Since 2001, Indonesia have implemented decentralized policy, but right now, until now, the implementation is not optimal yet. There is a differentiation among province who has a big funds and also human resources. There is a different with small provinces. Like also some provinces have limited of fund. This is also a challenge. The third challenge is a mismatch between national medium term and also with the sub-national medium term of plan. Because from the national medium term, the government tried to encourage the sub-national to develop sub-national medium term also as a guidance for the development. For the human resources, particularly for nutritionists at the field, the distribution is not equal. Some nutritionists still in the, I think, in the big island like Java, Sumatra, and Kalimantan, but in the eastern part of Indonesia, still limited of nutritionists. Also unstandardized of competence among nutritionists. But right now we are happy because I think last month, yeah, the government of Indonesia through Minister of Health already established the standard competency of nutritionists. This is our benefit also. The last challenge is the minimum capacity of nutrition planning and implementation. This is also regarding the lack of human resources and capacity. I try to identify what are the best practice from the Indonesia, from the field. The first is study by UNICEF on capacity on nutrition board 2017-18, yeah. The first is the very important is the political will and local leadership. Particularly how to put the nutrient target at the sub-national medium-term development plan, including budgeting. The second is now I think we are almost 8 years, we have a national provincial food and nutrition plan, including provincial. This is also as the guidance for food and nutrition planning at the local level. This is particularly for multi-sector platform. And also from the study, there are good collaboration between a government with university and health polytechnic. I think the presentation by Pak Arifin, this is also one of example how the government collaborate with health polytechnic to support the planning and policy. Next is optimization using the local budget for the priority intervention and nutrition problem. Some of the, I think not some, many of the local government already use optimum for the local budget instead of waiting for the national budget. And also some of province optimizing using the profit sharing fund or from cigarette excise for health and nutrition intervention. And the next is evaluation of village budget. This is funded by central government through Minister of Village. Okay. This is the study from the Banggai. Actually, Lanka study in Banggai, the first is advocacy to solve at the district level. There is like a champion by Bupati. Integrated health and nutrition services during preconception, supplementary, and also there is a media. This is very good example in Banggai. This is also from the global perspective, strengthen health system, multi-sector coordination, and also community structure. This is all. For the recommendation, we need human resource capacity assessment and mapping. This is very important. And also provide technical guidance, guideline related to function of human resources, and also conceptual framework action for nutrition specific intervention, and also conceptual framework for nutrition sensitive and specific. This is very important. Strong monitoring and evaluation. This is one data policy for planning and intervention. Last is one authority data, national authority. I think this. Now, this is the last presentation is during COVID-19. I tried to key points needed how to take action during COVID-19. The first is healthy diet, food supply. Second is maternal, infant, and young child nutrition. This is health services to continue provide essential services, and also management of wasting. Next is micronutrient supplementation should be continued as part of nutrition services, particularly for pregnant women and young child. School feeding program and nutrition, this also should be continued, but since school is off, school from home, this is quite difficult. That's why some teacher have to go to the school house to deliver the school feeding. The last is nutrition surveillance. This is a part of monitoring and surveillance because this is also as the basis of planning and intervention. I think this is my presentation. If any clarification, I'm very happy. Thank you.
Good morning, everybody.
Morning, Professor.
Good morning,
Morning. How are you today?
Hello, can you hear me?
Yeah, we hear.
Yeah.
We are listening.
Yeah.
Okay.
I'm listening.
The
Yeah.
outline of my presentation is as follows. Introduction, malnutrition in Africa, trends of nutrition status indices in Nigeria as reported in NDHS report, nutrition program, best practices and lessons learned from Nigeria, then conclusion. Malnutrition is one of the biggest problems that the world has been facing, most especially developing countries, Nigeria inclusive. There is need to put in place policies and programs that will improve nutrition across the globe. Some of the nutrition policies, practices, and success stories in Africa, and Nigeria in particular, are discussed in this presentation. Of course, this is a slide we are very familiar with. Malnutrition can occur as undernutrition or overnutrition. Undernutrition presenting itself as stunting, underweight, or wasting. Overnutrition as overweight, obesity, and diet-related non-communicable diseases. Causes of malnutrition, we are all familiar with this. We have immediate causes like inadequate dietary intake, then diseases. Then the underlying causes include insufficient access to food, inadequate maternal and child care practices, poor water sanitation, and inadequate health services. All these causes of malnutrition are what we try to address through the various interventions we put on ground in Nigeria, like policies and the rest of them, as you will see in the presentation. Then there are, like I said earlier on, malnutrition can be in form of undernutrition. You have acute malnutrition, which is wasting. That one is immediate effect of malnutrition. Then you have chronic malnutrition, which is stunting. That one is malnutrition over a period of time. Then you have acute or chronic malnutrition, which presents itself as underweight, as well as micronutrient deficiencies of some of the important micronutrients like vitamin A, iron, and iodine deficiencies. Then the stunting picture in Africa, I have tried to present this stunting picture in Africa from 1990 to 2018. If you look at the graph, the third graph in ash color is that of Africa. Then subsequent bars are different regions in Africa, like your North Africa, South Africa, East Africa. And consistently, the yellow bar represents East Africa. And they have the highest rate of stunting in Africa, while North Africa, the green bar, has the lowest rate of stunting in Africa. And that has been consistent over the years from 1990 to 2018. Probably this might be as a result of their diets. Then overweight picture in Africa. You see overweight and obesity are coming up as a public health nutrition problem globally, and Africa is not an exception. We have very high rates of obesity in some regions of Africa, up to 9.5% obesity prevalence of underweight, and this occurs mainly in South Africa. Consistently from 1990, the blue bar, second to the last blue bar, you have a consistent high rate of overweight in South Africa. And it is increasing, showing that overweight and obesity are becoming serious public health problem in Africa, particularly in South Africa. Then trends of nutrition status indices in Nigeria, as reported in National Demographic Health Survey. I have tried to trace the nutrition indices using stunting, wasting, underweight, and rate of exclusive breastfeeding from 2003 to 2018. This NDHS survey is done every 5 years to see how far we have gone, the progress made. If we look at stunting, the first bar, blue bar, represents the picture in 2003. Then 2008, 2013, and the last one, the yellow bar, represents the picture in 2018. If we look at stunting, we see that it is gradually going down because Nigeria has been progressively mounting a lot of programs. But because stunting is a chronic, it takes time to manifest, the effect is not very obvious. Then for wasting, there are some increases because some of the zones are not really keen in because we have so many states in Nigeria. And this is a presentation for the national. What is really making it difficult to see the influence of some of the intervention is that some of the states do not key in. And as such, they distort the figure of progress made. But the happy thing is that by 2018, the yellow column, you see wasting dropping drastically. This is because from 2015, a lot of intervention and programs were made in Nigeria, like the Zero Water Campaign, the Save 1 Million Lives, and that significantly dropped wasting. And wasting, you see it immediately, you see the effect immediately. Then underweight, you see some increase, then dropped again in 2018 because of all the intervention programs. Then for rate of exclusive breastfeeding fluctuated between 17 and 13% between 2003 and 2013. Then there is a sharp rise in 2018, up to 29% of women exclusively breastfeeding, from 17% to 29%. As I said earlier on, it's because of some of the interventions, particularly the Zero Water Campaign, where we campaign that no water should be given to babies between 0 and 6 months except breastfeeding. This table is just trying to show us the picture of the breastfeeding in Nigeria. It's sad enough that the success story is that Nigeria is predominantly a breastfeeding country. Up to 95% of women breastfeed. But the major problem, as I said earlier on, is giving breast milk with water. So that was why we launched the Zero Water Campaign. And those that give breast milk with water are up to 54% of women. And if we can really achieve our objectives on the Zero Water Campaign, you see that we can reduce this number that give water and breast milk. We can reduce it from 54 to up to, we can reduce it and increase the number of women that do exclusive breastfeeding. The increase could get up to 54% if we really achieve our objectives of the Zero Water Campaign. Then these are some of the policies, the strategies and programs we have in Nigeria to address malnutrition and improve nutritional status of all ages. We try to do life cycle approach to nutrition, although under 5 is the most critical, but we still have a catch-up period. So we do nutrition across all ages. Some of the interventions are putting in place nutrition policies and strategies in Nigeria, saving 1 million lives, Zero Water Campaign, investiture of nutrition ambassador and champions, observing National Nutrition Week, observing World Breastfeeding Week as is done globally, then the activities of civil society scaling up nutrition in Nigeria. Then I want to briefly look at these policies and strategies one by one. The first one is nutrition policies and strategies in Nigeria. This is an intervention by government to see that they provide, the policies provide framework for addressing the problems of malnutrition in Nigeria from individual, household, community, and up to national level. So it takes care of all the various strata in the nation. Then they guide identification of gaps and designs required for improving nutrition. Since nutrition is multi-sectoral, the different sectors in nutrition have come up with different policies to address their peculiar needs. Some of the policies that have been put in place from the different sectors, because nutrition is multi-sectoral, the different sectors have to put in place policies that will help promote nutrition in their various sectors. We have agriculture, we have health, we have science and technology, we have water and sanitation. All these areas have a role to play in ensuring adequate nutrition. So each of the areas have come up with a policy to help them implement nutrition and reduce malnutrition in the country. Some of the policies include National Food and Nutrition Policy, the National Health Policy and Guidelines, the National Agricultural Policy, the Agricultural Transformation Agenda, National Policy on Infant and Young Child Feeding, Early Child Care and Development, National Policy on Non-Communicable Diseases, National Policy on Food Safety and its Implementation Strategy, National Policy on Adolescent Health and Development in Nigeria. Just briefly, let me talk on the policies. The National Policy on Food and Nutrition is the main policy from where others draw their presentation, and it aims, like I've said earlier, to address problems of food and nutrition at different strata, beginning from individual to households to community and to up to national level. And this national policy on food and nutrition is that for the national. It has been domesticated by the various states. We have 36 states in Nigeria. It has been domesticated to take care of the various needs of the different states. This is the launch of the National Food and Nutrition Policy by the First Lady of Nigeria, Aisha Buhari. You can see her at the center on cream dress. And this was one of the activities during the National Nutrition Week in 2016. Then another document that is of interest is the National Plan of Action on Food and Nutrition in Nigeria. This provides framework, direction for implementing the national policy on food and nutrition nationally. And like I said about the National Policy on Food and Nutrition, the National Plan of Action has also been domesticated to reflect, to provide guidelines for the various states which have domesticated the policy to reflect the peculiar needs of their states. Then another document is the health sector component of the National Food and Nutrition Policy, ISFAN. As I said earlier on, all these policies are derived from the food and nutrition policy. This is the health sector, concentrating mainly on health and nutrition. It is the health sector approach to addressing the challenges of malnutrition in Nigeria and has particular emphasis on the first 1,000 days of life and other vulnerable groups. Then another policy is the agricultural sector food security and nutrition strategy. This one was developed by the Ministry of Agriculture to mainstream nutrition into agriculture and make provision that farmers will no longer be just involved in yield, but on the nutritional quality of their products. And they have brought in place things like biofortification, use of biofortified food crops, red, yellow maize, and the rest of them, integrating them into agriculture. Then the next program is National Policy on Food Safety and its Implementation Strategy. We are all aware that unhygienic food presents a big threat to nutrition. And if food is not prepared in hygienic condition, it results to diarrhea, and this is one of the serious causes of malnutrition. So this policy puts in place all that is needed to ensure safety practices in food in Nigeria. Then you have national policy on the health and development of adolescents and young people in Nigeria. Like I said earlier on, we know that adolescent period is the second catch-up period. When children are stunted, during the first 1,000 days and as under 5 they are stunted, there is still a catch-up period, the adolescent period, and we have focused on this set of people to see if they can really catch up from the stunting, since it's a period of growth, another second growth spot. So the policy puts in place all that is needed to address the health and development of young people in an internationally appropriate manner. Then these are some of the programs we have put in place to address malnutrition, save 1 million lives. Like the name shows, we are trying to save 1 million lives per year. And this has to do with health services, beefing up health services so that children can benefit appropriately from vitamin A supplementation, deworming, and pregnant women appropriately taken care of, iron, folic acid supplementation. This is essentially to beef up services in the primary care health services to save lives and reduce rate of malnutrition. Then we have the Zero Water campaign. Like I said earlier on, the major problem in breastfeeding in Nigeria is that women has not understood that you just give breast milk alone, and breast milk contains enough water to sustain the baby. Incidentally, Nigeria is in the tropics, we have a lot of sun, the weather is dry, and women, they cannot understand that you don't need to give water. But this Zero Water campaign, the major objective is to educate women that breast milk contains enough water and that they don't need to give water. And if we are making progress, but we are still moving. If we are able to achieve the full objective of the Zero Water campaign, that will significantly improve the percentage of women. Right now, we have 29% of women practicing exclusive breastfeeding, and up to 54% practice breastfeeding and giving water. If we achieve our aim from Zero Water campaign, we hope that we will get to 50% and above of women exclusively breastfeeding their children. One thing we have noticed from this Zero Water campaign is that it has increased the rate of putting babies on breast within 1 hour, because before they will start giving water, but with this Zero Water campaign, mothers are forced to put babies on the breast immediately after birth, within the first 1 hour of birth. And it is really increasing babies that are exclusively breastfed. Another program we embark on in Nigeria is investiture of nutrition ambassador and champions. This is the picture of the First Lady of Nigeria, Aisha Mohammed. She was given the investiture as ambassador of nutrition during the 2016 Nutrition Week. She was given, in a gallant ceremony, she was recognized as an ambassador of nutrition, and she is living up to her responsibility as ambassador. On Tuesday of this week, she organized a national conference on investing in nutrition, and she was able to bring many nutrition stakeholders, including the Vice President of the Federation, all important partners and development organs, to come and participate in the conference with a view to improving financing of nutrition in Nigeria. So she's living up to her expectation. Another program we embark on is to have National Nutrition Week. This was established in 2016, the National Nutrition Week. It was established in 2016, and the major goal of the Nutrition Week is to do advocacy on nutrition, help people understand what it takes to eat adequate diets. In Nigeria, many people don't eat well, not because they don't have food, but because they are not well informed. They don't know what to eat, how to eat it, how to combine the locally available foodstuffs to ensure good health. As you can see from the film, the major objective is to help sensitize communities. We go to communities, we do campaign, we do walk, talk shop to enlighten communities, enlighten individuals on how to ensure healthy diet for the whole family. Then this one, another program we embark on is World Breastfeeding Week. We join our colleagues all over the world to observe the World Breastfeeding Week. These are some of the activities during the World Breastfeeding Week in Nigeria. And we use the opportunity to really advocate for exclusive breastfeeding within the first 6 months of life. In fact, it was during last year's World Breastfeeding Week that we launched the Zero Water campaign as part of the activities for the Breastfeeding Week. Another serious activity in Nigeria is the civil society scaling up nutrition in Nigeria. Nigeria signed up as a Sun Movement country in 2011 and has other arms of the Sun Movement, but the civil society network is very strong in Nigeria, and their major objective is to mobilize non-state actors to advocate, generate evidence, build capacity, and stimulate communities to scale up nutrition in Nigeria. They do a lot of advocacy to key persons in Nigeria, like most of the states. Their governors' wives, through the activities of civil society scaling up nutrition, we've made their governors' wives nutrition champions to help advocate for adequate nutrition for all ages. For example, the governor's wife for Kaduna State is really doing a lot of work in nutrition to promote adequate nutrition in the states. Then another program in Nigeria that is very strong is the Maternal, Newborn, and Child Health Week. We have a week set aside to address pregnant, newborn babies and children, infants at large, and some of the packages they put in place for the week include immunization, deworming, use of insecticide-treated nets, health education, and care for pregnant women. Then the other program which is very strong in Nigeria is National Homegrown School Feeding Program. The beauty of this National Homegrown Food Feeding Program is that it integrates agriculture into nutrition. We use homegrown nutritious food to feed school children, and thereby enlightening farmers on the need to produce more nutritious food, and enlightening children on how to eat nutritious food so that they can carry the effects back home. Even within this period of COVID, we do take the packages, packed raw food to children at their home to continue with the program. Having said much about some of the programs we've put in place, why is it necessary that nations have to put in place programs, policies, and strategies to improve nutrition? We all know about it. Improved nutrition will result in increased IQ, which will enable school children complete their education and become meaningful to themselves, increase their earnings, reduce poverty, improve economy, and improve health status of all ages. I don't need to overemphasize the point that $1 US invested in nutrition will yield up to $16 US. So there is urgent need for all nations across the globe to invest seriously on nutrition by embarking on different programs, different activities as can be practiced in the various nations. Then for the first 1,000 days, we have a lot of activities that will be in place to improve nutrition. For the pregnant women, we have iron and folic acid supplementation, micronutrient powder. Then for the children, young children, we have vitamin A supplementation, micronutrient powder, provision of adequate complementary food, and ensuring that they are given adequate complementary food in addition to continuing breastfeeding. Then we have food fortification and salt iodization as part of the package for the first 1,000 days, the nutrition program for the first 1,000 days. In conclusion, I will say that Nigeria has put in place a lot of programs, facilities, policies, and practices to improve nutrition and reduce the ugly rate of malnutrition. Nigeria has up to 37% rate of malnutrition, but still, government needs to improve their commitments. The happy thing about this is that there is government commitment. At least they support most of these programs in conjunction with development partners like UNICEF, but they still need to improve their commitment to reduce malnutrition and implement already existing nutrition, to implement fully already existing nutrition policies to reduce rate of malnutrition. And all the stakeholders and organizers and our partners all of them should work together. One of the problems in nutrition is that because it's multifaceted, multi-dimensional, many people tend to take different directions and they don't need to have coherence. We need to have coherence, work together with a view to improving nutrition, not just in Nigeria, in Africa at large, and in the globe generally. Thank you for your attention.